I get the pleasure to introduce Ismail. Yeah, no, thank you for coming here. So it's my pleasure to introduce Dr. Ismail Rashid and to invite him to speak to a department deeply attuned to the impact of history on contemporary social responses to disease. Many of our department's members were in Sierra Leone during the 2014 Ebola outbreak.
So what is
Oops.
now one seminar but now one Sierra Leone and visiting professor and the lectures. I just want connecting water.
Welcome. Welcome. Thank you.
Department has consistently drawn attention to the structural context in which the outbreak arose and spread, and has worked to trace the historical path by which a nation like Sierra Leone, ravaged by centuries of exploitation, provides a setting for epidemics ranging from smallpox and influenza in the early 20th century to Ebola nearly a century later. In this work, our department members have been deeply indebted to the scholarship of Dr. Rashid, Professor of History and International Relations at Vassar College. Dr. Rashid grew up in Freetown, Sierra Leone, received his BA with honors in Classics and History from the University of Ghana, and then received his MA in Race Relations from Wilfrid Laurier University, and his PhD in African History from McGill. He joined Vassar in 1998. In addition to his work there, he serves as Vice President of the West African Research Association, and is one of two editors of Africa Zamani, the Journal of African History produced by the Council for Social Science Research in Africa, based in Dakar, Senegal. Dr. Rashid's books include West Africa's Security Challenges, written with Adeke Adebajo, The Paradox of History and Memory in Postcolonial Sierra Leone, written with Sylvia Ojikutu Ndakali, and most recently, Understanding West Africa's Ebola Epidemic Towards a Political Economy, co-edited with Ibrahim Abdullah. He's enabled all of us to consider West Africa's epidemics in the context of their deeper structural settings. Today, he'll examine government and local social responses to two major epidemics, the 1915-1916 smallpox outbreak and the 2014-2016 Ebola outbreak. He's talk on epidemics, state and society, in colonial and post-colonial Sierra Leone. Welcome, Dr. Rashid.
First, let me start from the bottom of my heart to extend sincere thanks first to the Harvard Medical School. I know that many of you were in the forefront of the response to Ebola in Sierra Leone. It was a major health outbreak. Sierra Leoneans are still sort of the consequences of that outbreak. It was a time when there were a lot of people around the world who were terrified to go to Sierra Leone, and I'm glad that some of you did make the commitment and go to Sierra Leone to help Sierra Leoneans, to help Guineans, and to help Liberians really roll back the tide of the disease. I know, just like other people who either involved in medicine or work in developing countries like Sierra Leone, some of you would always sort of ask yourself, am I going to make a difference? Is what I'm doing meaningful? Yes, it is meaningful, and yes, sometimes on the ground in ways that are not obvious to you, you do make a difference on the ground. And I would, again, as a Sierra Leonean, and the Sierra Leoneans were here, I'm sure they would convey my sincere thanks to you. Thanks to Colonial, we always talk about being in this together, thinking about what's going on in Sierra Leone, and sort of learning from each other. I learned a lot. This started off with me basically assigning Paul's famous article on structural violence in Haiti in my class, and my students getting very excited about that particular article, and also learning that Paul, who partnered in health, was part of really sort of this frontline again in terms of working with Sierra Leoneans in countering Ebola. But most important, and I think one of the ways in which partners in health sort of stood up in its work in countering Ebola is that it stayed in Sierra Leone. Unlike most humanitarians and most people who came during Ebola and left, I think that PIH stayed and made a commitment to stay not only to work with people who are sort of affected and who are living with the consequences of Ebola, but as PHI has done in other places, to really make a contribution that is going to be transformative. And I hope that Paul with PHI and Harvard Medical School, that you guys take the course. So I'm very happy to be here and to have this conversation with you. So rather than a formal extended presentation, it's going to be more of a conversation. And the conversation that I want to have with you is a conversation that really sort of puts two pieces of work that I've done together in dialogue. The first is really sort of a short article which was done at the behest of my PhD advisor, Marion Eckenberg, who wrote on One Society, then subsequently wrote on really social and medical history in West Africa. Well, I said, if Myron is retiring, what would I write that would speak to work that I'm doing, but also honor the kind of work that he's doing? And that was where epidemics and resistance during the First World War came from. I am not the first person to write about epidemics during the First World War. That credit, if any, belongs to a good colleague of mine called Vassar, who wrote his PhD on the World War I, the impact of the World War I in Sierra Leone. And about a good half of his PhD dissertation is actually on the medical impact of the First World War in Sierra Leone. I'm very happy that subsequently he has gone on and sort of published extensively on public health in the country. What I did and what the Vassar School did not do was to bring together my own concern, which was about really trying to understand social protest and social reaction against colonialism, and how social protest and social reaction against colonialism led to the reconfiguration of the colonial state throughout time. The second work that you're familiar with is, of course, the volume that we put together on understanding West Africa Ebola epidemic. So it's connected to that first work, but it's also connected to the second work that I did, which is understanding West African security challenges. And people always ask me, so what do you do? I said, I am a social historian by training. I am a student of peace and conflict by necessity. I write about peace and conflict because I come from a country that, when I was in graduate school, found itself in the middle of a civil war and was falling apart. So writing about slavery, writing about resistance against slavery is very interesting. But when I was in the field doing field research, is for every second question that followed my first question, every second response was about the conflict that was going on. And as a researcher, one of the challenges that I faced was, is it ethical on the ground for me to be asking the questions that I'm interested in, which was going to they were going to advance my professional career, or should I really sort of pay attention and try to contribute or try to intervene in ways in which people will be able to understand what was going on within their lives? And therefore, my path is seemingly interconnected path in my research sort of opened up. Epidemics and resistance during the First World War and understanding Ebola, of course, ask two different sets of questions. But I want to suggest that they're related. And I'm going to try to see if I can pull those relationships together and open up a space for us to talk about them a little more. So first is that these two works deal with epidemics that unfolded within societies that were being reconstituted after violent conflict. So the smallpox outbreak during the First World War occurred 2 decades after the British had really sort of conquered and incorporated the hinterland into a much more larger colony that is called Sierra Leone. And I'll speak a little later about what that incorporation of the British, what was called the protectorate, into the colony, what that meant in terms of the smallpox outbreak. The second outbreak, the Ebola outbreak, as most of you are are aware of, happened a decade and a half after a brutal civil war between the Revolutionary United Front, which was the main protagonist, and three successive governments: the All People's Congress, the National Provisional Revolutionary Council, which was a military junta, and the Sierra Leone People's Party government. So even though the Revolutionary United Front said its aim was to get rid of APC, when APC left power, it continued the civil war until the war was conclusively ended in 2002. So again, what to keep in mind, two societies which, after violent conflict, are remaking themselves within 2 decades are going to be forced to deal with epidemics. And what I posit is that by analyzing the nature of the epidemics and the responses of governments and some of the consequences, hopefully we can understand some of the historical and structural forces at play at different points in time. And we can be able to glean some of the historical continuities as well as discontinuities. In other words, when we look back at something like 100 years later and we look at some of the responses to Ebola, what are present in those responses that really brings echoes of the past in terms of how people respond to smallpox during the First World War. And the argument here is one that you're sort of familiar with, which is the issue of that the two epidemics point to continuing production of particular forms of structural violence that are rooted in the silent past as well as its present trajectory. The country continues to wrestle with the legacy of colonialism as well as recent international efforts. And I underline to refashion Sierra Leone, to remake Sierra Leone. It's not that Sierra Leoneans don't want to remake their country in particular ways, but they have to contend against post-colonial efforts and much more lately, and I'll talk about that, external efforts to remake the country in particular ways. So again, just a quick caveat. I know this is Harvard Medical School. I am among public health specialists and among doctors. So this is the point of view of a historian. The questions that I ask are about history and less so about medicine. So let's start the conversation by first looking at the smallpox epidemic of 1915 and 16. We know that by the end of 1916, smallpox had overwhelmed Sierra Leone, mostly northern Sierra Leone, an area where PIH works and which Paul knows very well. Historically, that particular area of Sierra Leone, which is roughly this area of the map. Now, what the last government has done is it has actually broken up this northern region of Sierra Leone to 2 different regions. So it's now northern Sierra Leone and northwestern Sierra Leone. But most of my research was initially concentrated looking at this particular region because this was, it was not the only part of Sierra Leone that the smallpox outbreak impacted on. One interesting thing was that you could actually trace the movement of smallpox doing 2 things. One, to look at the routes that connected Sierra Leone and Guinea, the old historical trade routes, which in spite of colonial efforts continued. Second is to look at the trade lines, which went approximately up to this particular point and then up to this particular point. So if you follow the trade lines, if you follow the trade routes, you can actually get a sense of how smallpox traveled in Sierra Leone. We know that the outbreaks were intense and sort of focused on particular chiefdoms in northern Sierra Leone, especially the chiefdom very close to Guinea. It was said that the outbreak actually came through Kindia, a town in Guinea, to Sierra Leone. It started in the harvest season of 1950. It subsided and then it intensified again much earlier on in 1916. So let's take a pause. So it's smallpox, 1915, 1916. It's occurring in the middle of the First World War, and I'll talk about why its occurrence in the middle of the First World War is important. So smallpox as a disease and the regions that it's affecting. What is it about this particular disease that stands out in Sierra Leone? Probably nothing exceptional that stands out. What stands out is the scale and the magnitude of the outbreaks in those particular years. It was a known disease. It was a known disease. As far as the late 18th century Winterbottom one of the sort of researchers, Combs, botanists, had sort of pointed out that the evidence of smallpox in Sierra Leone. And throughout the 19th century, when the Freetown colony, and I'll talk about the Freetown colony in a moment, was established, there have been sort of small and repeated outbreaks of smallpox. In fact, when you look at the period from the First World War until the eradication of smallpox in 1969-70 in Sierra Leone, smallpox seemed to go through every 10-year cycle would have some outbreak of smallpox in Sierra Leone. And Sierra Leone, by the way, in 1968-69, when the World Health Organization had basically gone on eradicating smallpox globally, Sierra Leone was found to be one of the places in the world where the disease was endemic. Proportionately, Sierra Leone had greater and higher incidences of smallpox than other surrounding West African countries. So there might be room there for people to sort of research a little more the nature of the endemicity and why smallpox was so prevalent and so endemic in Sierra Leone. So we have the outbreak. How did the colonial state at that particular point in time respond to the smallpox outbreak? And here there's a familiar story. The outbreak started earlier in the year. The colonial state only became aware of the outbreak of smallpox, especially in northern Sierra Leone, only in October 1950. So it meant that the outbreak had gone through a first phase. And even then, it had very limited medical personnel to deal with the epidemic. It sent 5 doctors on a rotational basis to help contain the epidemic. The doctors did what doctors usually do: isolated patients, administered vaccinations, which by then we know would protect people against smallpox. They fumigated infected houses, and they concentrated their efforts, especially around sort of the trade rivers, because this was where there were a lot of movement of people. And one of the districts most affected, Dixon Chiefdom, which is by the Guinean border, was momentarily quarantined until smallpox subsided. Again, I want you to keep in mind, because we would see echoes of that during the Ebola outbreak. By the time the outbreak was contained in the city, as I said, it had affected all of the colony. But the impact was differential. Northern Sierra Leone suffered the most. Freetown, which was the site of the old colony, also had smallpox outbreak, but less people died in Freetown than other parts of the colony. So let's talk about popular responses. So you have the state response, let's talk about the popular responses. So first thing is that people usually, because smallpox was a known quantity, is that people didn't wait for the colonial government to respond to them. In fact, at that particular point in time, the colonial state was very thin on the ground, whether it was in terms of administration, whether it was in terms of health personnel. It was just a thin state that was trying to institute itself. They did things that were very similar to what the doctors did. They isolated and inoculated the sick. Violation, which is you basically scratch the pulse, I think, and then you introduce it into a non-infected person over time. This is something that medical historians have pointed out that's well known in many areas in Africa where smallpox have existed. So they did that. These are tried and tested strategies. They also consulted local healers. And local healers in Sierra Leone fall into sort of a broad range. So there are people who deal basically, who you could sort of consider herbalists, who would sort of treat the body and would prepare either potions or sort of medicine. Some of the medicine they would rub on infected skin, hopefully to deal with the scabbing that comes from smallpox. Again, on the other end, you have people who combine healing and sort of dividing. In China, we call them Moriman. So you go to them, they would look at what else is going on in your mental, spiritual, and divine universe, and sometimes they would pair that with so those people were sort of the first line responders. And where that didn't work is people did what they usually do, which is cope. And at the end, once they reach the limits of their effort, in northern Sierra, which has been Islamicized, once the epidemic overwhelmed them, there was a sense of quote-unquote fatalism. This is beyond our capacity, it's due to Allah, Allah sent it, this is not the work of humans. But beyond responding to the outbreak, which is interesting, which one would say is a public health response at a local level, what I'm much more interested in and what I spend time in the article and sort of larger work looking at are the other responses. And these are responses to the state and the medical personnel on the ground. So, of course, people were suspicious. They resented colonial medical effort because they were intrusive and they were restrictive. So there's one thing to say, I'm going to accept medical treatment and medical advice. There's another thing to say that we're going to basically go into your heart. We're going to spray chemicals into your heart. We're going to restrict movements. Those are things that really just simply got on people's nerve. So people conceal the disease. They refuse to accept medical advice. And in some cases pretended to accept advice from British colonial doctors and ignore it as soon as the doctors left. Or they just simply exited.
Can I ask a question?
Yeah.
So, is the word fatality of smallpox? Can you get well from it?
Oh yeah, no. So this is not
Case fatality. I mean, again, it would depend on the setting, the host substrate. But and feel free to chime in, Scott. Most people would recover, as is true with most viral infections, which is why some people were suspicious with claims that Ebola was always.
Yeah.
It's distinctive because of the rash, whereas a lot of febrile illnesses that can kill would be impossible to sort out. But smallpox, I think a lot is known about it.
So people just waited to get over it.
Oh yeah. So
But the transmission is in a few feet of infected respiratory secretions. So that meant the healers and the family caregivers were in harm's way.
And there still is an impressive fatality rate and disfigurement for those who do survive it as well.
20%, 30% sometimes.
I would have waited.
So, but also, I mean, with new techniques, again, just in terms of response, with new techniques that came in with what is usually called Western biomedicine, is vaccination, which really creates an immunity belt in particular areas where there are outbreaks. Is that people were asked to take in vaccination. You're introducing things into their body, and some of them were afraid of quote-unquote being injected with juju. They were not particularly familiar with them. The other reason why people protested was that colonial measures, which were usually top-down and heavy-handed, restricted trade, it hampered the movement of people, and it would withdraw labor from people's daily lives. Because, for example, the fumigation of people's houses was done with local labor, which was taken from. People also resisted medical team because they mistook them in that earlier period for military recruiters because it's the middle of war, second as tax collectors. And usually the mistake that the doctors and the colonial state made was that they traveled with messengers at periods that were considered periods that were sort of tax collection periods. So you just scare people away because at that particular point in time, is that even though doctors were slightly different, they were all white European colonial officers. They look the same, so their functions might be similar. The chiefs did not help, and the chiefs did not help because they were caught in the bind between enforcing colonial orders and also at the same time protecting their people. To be on the side of colonial officials at the time when people were going through hardship meant that chiefs is losing whatever authority that they had left. So by 1916, was the colonial response effective? The overall picture was that it was unlimited. It was of limited impact. The Sierra Leone rode out the epidemic at that particular point in time. What Sierra Leone did not benefit from, and I'm not going to sort of spend a lot of time on, was that famine and the influenza epidemic in the next 2 years that followed the smallpox outbreak. So what I'm going to try to talk about sort of very quickly is to make sense of some of the political economy and the dynamics of what is going on. So how do we understand the political economy of this historical response to the state and society during the smallpox epidemic of the First World War? So first, I would suggest it was both symptomatic and reflective of the ongoing British and European processes of restructuring restructuring the economic, social, and political landscape. The processes were consolidating new hierarchies of power, especially over people who, about 2 decades earlier, had actually had sovereignty and control over their lives. It's not that Sierra Leone or the West African states have not been connected to the Atlantic world or the Atlantic economy. There are about 2 or 3 centuries of slavery that have preceded this particular period, and many of the chiefdoms that were part of this new colonial order were implicated in the slave trade. And chiefs were part of capturing and sort of trading people. So there has been this relationship with Europeans for a very long period of time. But until the 1880s, most of Sierra Leone, the interior of Sierra Leone, so if you look at the map very roughly, most of the Sierra Leone, you had people who nominally were sovereign and had control. They had various chiefdoms existed in a hierarchical relationship to other chiefdoms, but at the end of the day, it was Africans controlling their own political space, their own social and cultural life. But from the 1880s, as some of you know, what we had is a new dispensation where that space, as well as all of the surrounding states and most of Africa, came under colonial rule. So that particular period is a period where African societies are coming to terms with this reordering of the space, but also reordering of their political and cultural life. Sierra Leone is interesting in one particular sense, in this, in the fact that this particular area is one of the oldest colonized areas in Africa. From around 1787, but from 1808, people get from where? Africans. From the United States, who had fought in the American War, or Americans would call it War of Independence, they would call it War of Resistance and Liberation. People who had fought against the British in Jamaica, and people who had escaped and had become free people in England, all moved to this particular part to essentially try to establish a free settlement. They would do the same in Liberia. The difference between the history of Sierra Leone and the history of Liberia is that the people in Liberia would maintain some form of autonomy over their lives. We always say Liberia was independent and was not colonized by any country. In this particular part, the particular group of people who came here, 1808, had actually, because the colony wasn't doing well, was taken over by the British. So from 1808, you've had a very long history of colonization in this part of the world. So the extension of British rule to this part of the country came much more later. And what that did, and this is important for understanding the outbreak of smallpox and why more people died in this particular part and this particular part, and also understanding the differential impact of Ebola, is to understand the relationship between the old Freetown colony and the protectorate vis-a-vis the British. So the old Freetown colony had people who, all throughout the 19th century, were both people who saw themselves as being loyal and attached to the British, but who also resisted the British. People also had a strong sense of their Africanness, and the sense that they came to that particular part of Sierra Leone to freedom. And their relationship with the rest of the country would be one in which there would be a struggle for power that was not resolved until 1951. People in Freetown, because they were descendants of free Africans, quote unquote, they were more civilized, much more educated, and they saw themselves throughout the 19th century as equal of British people. And there's a reason. Towards the end of the 19th century, the Creole population, the descendants of those particular people, had a level of education that was higher than most parts of the world, was even higher than in Britain. 90% of Creole people sent their kids to school. And by the end of the 19th century, they had also produced doctors, they had also produced surgeons. So that's the first way to understand it. The second way to understand it was that this colonial expansion put additional demands on people who were colonized. The reconstitution of Sierra Leone as a colony during the period of the new imperialism, it meant that the British demanded more revenue. Colonies should pay themselves labor to put the infrastructure of colonial rule in place, and also food to support that particular labor. These demands would increase and intensify during the Second World War, in which the various colonies were not only required to support themselves and the changes that were going on, but to support the imperial war effort. So the outbreak of the smallpox came during that particular period in which the British were asking for more from people who were being colonized. It did not help that these demands were coming at a time when the climate, the psychological erratic, the rains were off, the brushing and the burning of bushes were off, and so were the harvested. But I'm also interested in that particular subject. I also understand the ways in which Africans did not just roll over and die, the way Africans continue to resist colonial hierarchy. And the smallpox showed, if you look at the way in which people contested the state, people avoided medical officers, they were plugged into some of the measures that people had used to resist the state, even after Africans had lost the war on the battlefield. Another point that was also very important, and I think should be put on the table. Remember I talked about the medical officers that were sent to deal with smallpox. So you have to think about a situation where by the end of the 19th century, you had Sierra Leonean doctors who had been trained in London. Some of them had been trained in tropical medicine. One of them, Africanus Otten, was the senior colonial medical officer who at one particular point in time was treating both Africans and European officers. But by the late 19th century and the turn of the 20th century, you had a situation where the colonial medical service had become segregated. And African medical practitioners were being kept out of the colonial medical service and were being, so they could either go into private practice or they were put into what was called the native medical practice, or what was called dispensary. So their role was much more de-emphasized. And what was interesting when you look at the response towards smallpox and some of the complaints that were in the newspaper were the ways in which were complaints against this elitist Britain saying that we can't understand that you have a crisis going on and you're keeping out African doctors. You're not using African doctors as part of the crisis. Two other points that should be underlined. There are no indications that the British and the French coordinated their efforts insofar as dealing with this outbreak is concerned, even though it seemed to be a regional outbreak and also seemed to be a cycle at a time when, during the First World War, I think that there were also smallpox outbreaks in Central and Eastern Europe. Again, let me underline this point in terms of just closing up, thinking about the historical dynamics around the state's response and people's responses to the smallpox epidemic of the First World War. Smallpox might have had lethal medical and social consequences, but it was not an unknown. People knew the disease. People could write out the disease, and people could deal with the disease. So let me turn very quickly, and I'm going to make, I'm not going to spend a long time on Ebola. It's something that it's an epidemic that is in living memory, and in the place that you are, about medical school, I'm sure that you kept up with the outbreak. You know what the outbreak was. A number of things sort of stand out about Ebola that should let you think a little more about sort of the picture I just painted about smallpox. So whether you go to the index case of Umamu or you go to Finda Nyuama, who was the traditional healer in Sierra Leone, who are usually pointed out as the two sources of Ebola in Sierra Leone, both of them came from Guinea. Both of them came from Guinea, showing the ways in which it's very difficult to talk about these countries as isolated. Unlike smallpox, which started on the northern side of Sierra Leone, Ebola came from the eastern Guinea border. The second point that needs to be underlined with Ebola, and again, this needs to be underlined because it's part of the making of the crisis of the response towards Ebola. Ebola might have been a known disease. So if you're in medical school, if you're interested in this, you know Ebola. You follow the news. But I want to take it to the level of communities which do not have access to the knowledge that you have and are confronted with a disease called that turned out to be Ebola. In other words, on the ground, it was an unknown. It was an unknown. So that the first, and because when it enters its odd phase or odd stage, some of the symptoms that people display are similar to malaria, typhoid. People know those. People know that. So their responses, the initial response was within that particular framework. Third, the only thing that comes close to really trying to go into people's head to think about Ebola is to think about the flu which followed smallpox in 1918 and 1970, because the flu was widespread, its mortality rate was very high. So the only way to think about Ebola is to think similarly, but it was different from the flu. It was different from the flu because its geographical scale was much more larger insofar as the region was concerned. The efforts to control it was much more complicated. First occurrence of the disease, as you all know, that became transnational. This was the first time that Ebola crossed so many boundaries. And so it was not, I always underline this, it was not only a disease of Sierra Leone, Liberia, and Guinea. It was also a disease of the United States, of the United Kingdom, of Italy, of Nigeria, because the Ebola virus, smart virus, made its way to the United States. Kenya, Ebola from West Africa, the cases came to this country. Smallpox might have generated fear, but Ebola generated far much more widespread fear and panic. And we talk about one district in Sierra Leone being quarantined. With Ebola, we end up with really 3 countries effectively being quarantined by the world. Let me end up with a number of points to think about, again, the patterns of sort of structural violence and things that might show continuities and sort of difference. So the first difference here is Sierra Leone was not a colony anymore. 2014, Sierra Leone was an independent country. It has been independent for at least 50 years. Second, and this is also important, whilst the responsibility for responding to disease might have been not only local, but also the purview of the colonial state. 1915, 1916, you had international agencies responding to disease, but no way as powerful, no way as organized as you had in 2014. So we understand by when Ebola broke out that the responsibility for responding to infectious disease like this are not simply local or communal responsibilities, they're not simply country responsibility, but they're also international responsibility. So that, in terms of context, in terms of continuity, this was what was different. An independent country in the context of a nation or of a world where public health had become an area where there is shared sovereignty and there's shared response. With the latter in mind, this is what allowed us to pitch the question that we asked in the second book. 40 years of experience of dealing with and containing Ebola in Eastern Africa and Central Africa. The world has 40 years experience. In some cases, there are lessons learned. In some other cases, there are lessons learned. So how did we, not only our Sierra Leonean communities, Guinean, Sierra Leone and Liberian states, but how did we, through WHO, through CDC, and all of the bodies responsible for responding to diseases like those which tend to overwhelm local capacities in Africa, how did we get it so wrong? How did we get it so wrong? And I'm going to make a couple of points and then round up and hopefully open it up for questions. So the first area where we definitely sort of got it wrong, again, I would underline this, is the question of knowledge, local knowledge, and local understanding of sort of the disease environment, what's present in the disease, and how to sort of respond to it. It took a long time locally for people to understand the nature of the disease that they were dealing with, that it was not Lassa, it was not cholera, it was not malaria, that it was something new and something that is within their game, needs new knowledge, new ways of understanding and responding to the disease. But people who figured it out, by 2014, we had known that it was Ebola. It took about 6 months for them to figure it out. 6 months is a long time in an Ebola outbreak, and that was partly why it became an epidemic. After 6 months, the challenge for the state and the international community was how to get the message and tell people that this was a different disease. Paul usually makes a joke about this and says, one of the messages around is, Ebola is real. Ebola is real.
A lot of your tax dollars went into billboards.
You have to meditate on that for a moment. Ebola is real. How can you say Ebola is real to people who are losing their families, who are dying, for who all of the symptoms and the consequences of the disease surround them? So you have the Ashpusad around the table and thought that it was a good message support. So the environment, which is called an environment of sensitization, was a problematic environment. It was also a very competitive environment, so different kinds of competition going on. So there's people in Sierra Leone, Guinea, and Liberia who are competing, NGOs who are competing, so we want to be the ones to go sensitize people. By the way, we joke in Sierra Leone that we have regimes and governments by sensitization. Anything that happens, they have to sensitize people. The second, there is also sort of a partisan battle going on between the state and the international community of how to put forward this message. Well, it's a very difficult environment to get your message out. It's an environment where the majority of people are actually alienated from the state. We're slowly rebuilding trust in the state in Sierra Leone. I don't know how much of that trust will ever be fully built. At least one of the things that's happening is we're getting people to go out to go vote. And people are, in Sierra Leone, what is politics good for? Well, one of the things that politics is good for is that not that the governments are performing very well, but at least people feel that they have the power to go vote out guys that they don't like. So we've changed government in Sierra Leone about 3 different times. Is that we know you're not going to do very well, but we're going to remind you that there's a day that's going to come that we're going to vote you out of government. So within that particular environment of alienation and trust, it was very difficult, just as in the case of smallpox, to get the message out. Should we trust what the government is doing? The second point that I want us to think about, again, remember, as I said, that one of the contexts which makes this conversation possible is the environment within which it's happening. Sierra Leone is a country that is recovering from a nasty Libya war. And I come from Sierra Leone. I could remember very vividly starting off at Vassar, 1998, 1999, asking my colleagues who were very good to say, can I go to Sierra Leone? There is a negotiation and negotiation process. They want me to be there. Can I come? And I remember being on a rickety helicopter with the U.S. ambassador, the British ambassador, and people in an NGO going to Sierra Leone to go dialogue with rebels. My mom didn't know, my family and people in Sierra Leone didn't know that I was in Sierra Leone and I left Sierra Leone at that particular point in time. But one of the highlights of that particular, that's a very short trip, and you had a copy of that was 15 hours long. One of the highlights of that trip in 1999, when the rebels invaded Freetown, was to travel through the length of Colonial from Cotton Tree all the way to the eastern of the city, and to see every single car on the road completely charred, and to see rows and rows of others completely burnt down. So this was, and I don't wish war on anybody. So if you're somebody who supports and likes and thinks that war can prove it, you have to live through war. I don't wish war on any people or any society. And for Sierra Leone, we talk about the lost decade, but it probably puts Sierra Leone way back. This was a country that was already suffering from some of the poor decisions that were made in the post-colonial era in terms of the choice of governments that were the decision that the government made of becoming sort of a one-party dictatorship, and the fact that before the war that social infrastructure deteriorated, including medical facilities, and you had a war on top of that. By the time the rebels went to the table and negotiated, there was very little left. It did two things. One, it put her in a particularly vulnerable position in terms of responses at all levels of society to new crises. Second, it created an opening for the further attempt by external agencies and forces to remake the country. So 1980s, 1990s, if you guys were sort of following developments in Africa, one of the nice things that the good boys of Washington did was that they decided that we needed to structurally adjust our economy because they were not performing very well and we had too many debts. And they're good guys in Washington, and all of us agree now that one of the terrible consequences of that particular period, or the outcomes of what was called the Washington Consensus, was that it gutted most social institutions. And instead of saying, as we're sort of discussing there, instead of saying mea culpa, we got this very wrong, is what they decided subsequently was that what we're going to do is you can restructure the economy, but we're going to put money for you to begin to do what was called poverty reduction. I always say one thing that happened that shocked me in my lifetime was that we went in Africa from talking about the politics of development to talking about the politics of poverty reduction. That was how bad it was. I think they recovered some of the language of development now, but for a chunk of time, it seemed that talking about development in Africa was impossible. What the discussion was about was poverty reduction and poverty development. So in the post-war period, what we have is a situation where we are the United Nations, which intervened in Sierra Leone, spent tons of money in first rebuilding the political landscape. We are the World Bank and the IMF, who also spent a ton of resources trying to fix the economy. And I'm going to end up at this particular point in time for us to understand, to get a picture of where Sierra Leone is. So people ask me, so where is Sierra Leone at this particular point in time? I said, oh, if there's anything that came out of the war, it was that it opened up the political landscape. We have political parties. We have about 12, 15 political parties. We have over 60 newspapers for a country of 7 million people, some of which come out maybe once every year or so. So we have as free a speech and as contentious a political landscape as you can. Our elections are problematic, but they do signal that people can change options among sort of a group of really not so nice guys. On the other end is that the country has really struggled economically. our economy is still very much an enclave economy. And you hear about Sierra Leone, people talk about diamonds. Please don't drink that Kool-Aid. Diamonds have not been a major stay of the Sierra Leone economy. And Sierra Leone is a potentially rich country, but it's not a rich country. So we have a situation where after the war, if you're actually coming from almost zero, your growth rate will be very high. So we have one of the highest growth rates in the country, in the world. But
Number one in 2013.
number one, but what are you growing from? So we're growing, but infrastructure in the country, especially social and health infrastructure, was as bad as it was probably before the war. We had, about 100 doctors at the outbreak of the Ebola epidemic. So we have a landscape which was a landscape where it was politically open, but socially and economically, there wasn't much development going on. And whatever little development was going on, and this is where I'm going to end up in the story, accelerated the divide between this part, which probably has about a third of the population now in Sierra Leone, and this part. So 70% plus of your doctors are concentrated here and serving only a small percentage of the population. Your hospitals are here. We had a brand new hospital in Kenema, Eastern Sierra Leone, which was built with American support and money, and where research into Lassa fever was being done. The Lassa unit where the research was going on, supposedly world class. The rest of the hospital was pitchwork. And this was one of the places that became the epicenter of the Ebola epidemic when Ebola got into the world. I'm going to stop at this particular point. As I said, I hope it's as current a picture as I can give, and I hope that it's opened up some room for some questions and some conversation.
Thank you, Dr. Rashid. I think you've proven there's always a place for good historical analysis in a medical school. So, thank you. And
I have kind of two intersecting questions. Thank you for that talk, Professor Rashid. It was I'm an historian, and I felt kind of tribal affiliation here. It was nice.
Tough place to hold your own from Becca.
Fighting it out. So two intersecting questions. One about how to tell, the kind of narrative, comparative narrative that you opened up today, and the other about, the conclusions that you draw from those. With regard to the smallpox epidemic during World War I, one of the interesting things to me as I was listening to you talk about the resistance in Sierra Leone in this colonial setting, occupied hinterland of the country in 20 years before or so, is that in England, right before Sierra Leone was occupied, there was similar resistance against smallpox vaccination. And as late as 1898, when that occupation was still going on, there were, very dramatic anti-vaccination essays still being published by elite members of English society. And so, the resistance that you're talking about is really transnational and a feature of, the role of epidemics in the state much more broadly than, the specific colonial context. And so the first question is, as an historian, as somebody thinking about Sierra Leone and, the particularities of this colonial setting, how do you think about the world, and what's the role of the kind of analysis of what's international health by this time in how you think about epidemics in colonial Sierra Leone? The second question gets to the points that you ended on about accountability by external agencies, particularly structural adjustment and its impact on the Ebola epidemic. So Sierra Leone's first president was a doctor in the Colonial Medical Service. And in his first 10-year plan, which was talked about a lot at WHO, World Health Assemblies, talked about as an unfunded mandate again and again and again, year after year, public health, the National Health Service, which they named after the British National Health Service, was their top priority. And so, I'm wondering what role you see this mandate of providing health care at the level of, the top priority of this new state, this post-colonial state, had in Sierra Leone, and what the impact of its failure, a deliberate failure on the part of the people who persecuted, I would say, the Washington Consensus, what role its failure had in the upheaval in the state during the Civil War that, as you point out, had such a profound impact on Sierra Leone's susceptibility to Ebola. In other words, how important in Sierra Leone and maybe more broadly in post-colonial states more generally is this idea that everybody has a right to health, that everybody and that the state's role, first and foremost, is to make it available.
Well, he's right. I'll just say that a lot of, I don't know if you have had a chance to look at this, but
I haven't. I'm looking forward to it.
A lot of those questions are addressed in some depth.
Yeah.
They're fantastic questions.
Again, thank you very much for the questions, and as Paul said, they're great questions, and some of them are good. Both of them are going to try to be able to make quick comments into the quick response. So I like the point about sort of thinking of this not only as a local moment but as a transnational moment in all kinds of ways. So being situated in the First World War, again, I was that. It's not really sort of a world war, it's a European war in which the colonies are sort of mobilized, for European nations at that particular point in time to sort of sort out their tribal and sort of national identities. It just had colonized people. But still, it did leave imprints on colonized people. And colonized people were part of that particular historical moment. So that's a good point to underline. Second, as I mentioned, to look at the outbreak of smallpox only from a localized and sort of Sierra Leonean context makes you lose sight of sort of a much more bigger picture in terms of sort of what's going on. So again, thanks for the information about the fact that just before this, one of the things that kicks in much more later is, as you said, once vaccination was seen as sort of an effective way of really developing and sort of creating not only individual but herd immunity, is that the bigger states, I think Sweden was one of the first states to effectively at one particular point in time immunize its population. So there is a concerted, but it's a slow and inexhaustible process that leads to 1970 when the disease was eventually sort of eradicated. And it's interesting because you had cycles of vaccination in Sierra Leone, but it was during the post-colonial period, as you said, based on this commitment, both by individual governments, but also after much debate in WHO. And it was the Russians who were eventually able to get it on the table to say that we support a move to globally eradicate smallpox. It was eventually globally eradicated. So yes, so I keep in the work as much as possible a transnational picture of what's going on. The notion of resistance is really sort of notion that I'm not only thinking about what's going on in Italian context international, I'm also thinking internationally what's going on. The framing context is moral economy. The moral economy of quote-unquote pre-industrial societies, of people who are in the process of transformation and change, who are drawing from sort of a disparate sets of understanding of the world, local communities, and sort of the challenges or the new things that are thrown at them that they see as oppressive or that they want to. So what frames, as you say, when you talk about protest, so part of it is, again, I'm a great fan of E.P. Thompson with criticism. So the sense or the notion of protest that I'm sort of drawing on is not protest that's only locally conceived or conceptualized. It's protest that's also broadly conceptualized. So that's, I would say, sort of my quick response to the first one that you raised. So the question of sort of accountability, I think the public health accountability, I think there are two levels here. I think one, there is, as you said, a national level. Having Samuel Magai as the first Prime Minister meant that you have somebody in office that already sort of an inbuilt commitment to the improvement of public health. And until the train went off the rails in Sierra Leone around sort of the mid-1970s, is one of the things that was successively on the table were periodic development plans, of which health, education were part of that. I think by the mid-1970s, we began to lose the script. And we lost the script not only because we had an elite in power, which by 1970s had run out of imagination. Most African political elites in power by 1970s had run out of imagination, partly because the challenge of independence, the challenge of administering states which were very young, states where the demand of the populations that they were essentially governing or trying to govern, in some ways not only exceeded their ability, but also exceeded the kinds of resources that were commanded or sort of needed. I've always said one of the ways you think about corruption in Africa is that the elite, once the elite lost the script, they decided that what we're going to do is governing is too hard, let's loot. But part of the challenge at the local level is losing that particular script. And in losing that particular script, the focus on public health, the focus on education, the focus on a whole range of social commitments disappear. What is replaced by until I think now within Sierra Leone and within most African countries, I think we understand that what we're trying to recapture again is the narrative of saying that this is absolutely important and it must be, a development. In losing that particular script, in this landscape of restructuring, marketization and liberalization, not quite right, but working close to, one would argue, close to still be negotiated entitlements that people were sick, they could go to hospital, they could get treated for relatively cheap. We lost that script. 1980s, 1990s, public health entered the rim into the market. It entered in the rim, and we're still very much there. In other words, those who can pay are the ones who get the best possible service. Government hospitals, government dispensary went into cost recovery mode, which meant that you pay. It wasn't simply a question of, as you said, a public good or public entitlement. It became sort of a question of a market commodity. If you can buy your health, it's fine. As I said, in Sierra Leone, we're trying to recover, and most African countries were trying to recover that. The Free Health and Maternity program was a part to recover that. Public health being a right, I think we're a long way from that. In terms of sort of public discourse. We're still very much in the marketplace. The new government in Sierra Leone has talked about it, but in terms of the areas in which they've anchored or decided to pitch their tents, I think it's education. It's not health. Education, it's not health. So we're still sort of internationally, again, we still have this debate here. We have this intense debate around public health. The debates are also sort of ranging in terms of what's happening to the NHS in London. So on the ground, that debate about sort of putting it on the table that this expensive item is a public right and it's a public good and needs to be paid for and needs to be accessed, and even if you want to cut it at reasonable cost, I don't think we're there yet.
And Aaron, I would just add the second section of the book is called The Neoliberal Affliction. Different countries, similar afflictions.
Thank you very much for your lectures. I have 3 questions.
Introduce yourself, though, Christophe.
I'm Christophe. And
That doesn't help much. Head of Women's Health in PIH Haiti. Here is a master's student.
the first question is how the politics of neoliberalism influenced the outbreak of Ebola. The second question is you talk about the conflicting situation that rebels that are fighting against together. How, in a historical perspective, this conflict can influence the outbreak of Ebola in Sierra Leone? And the third question is how the political power around Sierra Leone, as we call that countries around political powers, and how they influence. What is the influence of this political power on the social context, the socio-economic context of the country, and finally to look at the relationship with outbreak of Ebola.
Better be some Sierra Leonean questions coming up next. Punishment will ensue.
Okay, Christophe, I didn't get you. I got the first and second question very clearly, but not first and third question clearly, not the second question.
The second question is about I was talking about neoliberalism or its influence outbreak. The second question is about rebels. In your lecture, you're talking about conflicting situation between rebels and Sierra Leone. How this, in a historical perspective, the conflict between rebels can have an impact on the Ebola outbreak. Is there any relationship?
Okay, so the first question, I didn't want to say this, but I'm going to say it. The overall, again, as Paul pointed out, this chapter on neoliberalism, one of the core arguments of the book is that Ebola is not simply about a disease outbreak. Ebola is a neoliberal affliction. Ebola is a neoliberal affliction. And one of the things that we pointed out in the book and the way in which the different authors, in terms of their arguments and how they position their chapter, is to show the way in which, first, the Washington Consensus and the neoliberal restructuring of the state affected, first of all, the integrity of various African states. It wasn't the Washington Consensus, it wasn't structural adjustment which caused or created the wars in Sierra Leone and Liberia, but it definitely exacerbated some of the underlying conditions on the ground. In other words, the states, whether it's Sierra Leone, Liberia, and sort of Guinea, had started running into problems by the 1970s and 1980s. If the economists of the World Bank, now they have anthropologists, now they have other groups of people say, no, you have to look at it from a much more comprehensive perspective. If the economists of the World Bank had said, let us think very carefully, let us look at what's going on in this particular society, maybe they would have tempered some of their prescriptions for change in those societies because they realized the havoc that the structural adjustment conditionalities did after the fact. So when we say it was a neoliberal affection, we looked at the way in which it affected the ability of societies at the bottom, communities, to function and to be able to respond to crises like this. So life for people at that particular level outside Africa is very, very difficult. And the economic condition of Sierra Leoneans post-independence with expanding population is not improving. So if you think that when you look at the United States, people say there are people in the United States, for the vast majority of the labor in the working classes here, real income or wages are sort of stagnated. I want you to think about what that means for countries like Sierra Leone, Liberia, and Guinea, which are really at the top, last bottom 10 of the Human Development Index. The second level at which we said you should look at it being sort of a neoliberal crisis is the way in which structural adjustment and poverty reduction strategy papers hampered government abilities, even when you have well-meaning government ability to put together comprehensive public health systems that work. And the way in which, in that circulation of labor that is part of the making of this neoliberal era that we live in, this globalization era that we live in. Now, somebody asked me a question in London, so how best can the British help Sierra Leone? And I smiled. I said that.
Can we go back in time?
I said, no, I'll make it simple for you. I said, if you go down the road, you see that big hospital not too far from LSD, I'm sure if you do a census there, you're going to find a lot of Sierra Leonean nurses in that hospital. I said, so this is not a question of helping or giving charity to Sierra Leone. This is a question of understanding the circulation of labor in this neoliberal era. And you could do two things for Sierra Leone. One, you could actually go help and train and educate people on the ground. You could do that. Don't give people money. Go help educate people so that where those nurses and doctors are coming from, you can create more so that these people can circulate. It's very difficult to stop the movement of individual professionals. But if you want to expand the basis of medical, the numbers of medical personnel, maybe some would stay in Sierra Leone and they would help. And a lot of them did go back to help in Ebola. The third level at which it was a neoliberal affliction, and this is easy, is how and why WHO missed it. Is how and why WHO missed it. And third, and finally, what it took for the world to respond to Ebola. What it took for the world to respond to Ebola is that this is no longer a group of black people in 3 countries in West Africa who are going to suffer from this. This is going to be a global pandemic. It's not only Sierra Leoneans, Nigerians who are under threat. The Americans, British, and other people are going to be under threat because if we don't get this thing under control, it's a major security crisis. Let me respond quickly to the last this last question, the second question quickly. I talked about how the rebel war affected the Ebola crisis. Whatever infrastructure existed, it completely destroyed health infrastructure. These guys did a number on Sierra Leone. Not every single Sierra Leonean community was affected by this war. It really damaged and destroyed whatever infrastructure existed. And another thing that it did was that people like me sent a lot of well-educated Sierra Leoneans into exile, including medical personnel. The last point that you said, the influence of the regional powers in politics and how they affected sort of the response to the crisis. The three governments in the 3 countries are not very good governments. They're not great governments during the Ebola crisis. And one way in which it was manifest, one is that they denied the crisis. They tried to hide the fact that we had an emergency sort of unfolding. When they raised resources and money, they stole some of the resources and money. We have a commission of inquiry that has been set in Sierra Leone now about how Sierra Leonean government sort of mismanaged it. Someone trying to hide what was going on the ground is due to one. These are regimes that want to politically survive. You don't want a crisis that would threaten their stability. Second, this is sometimes where you have to step back a little and try to understand some of the dynamics of what's going on. Now, Africa has been a place where international organizations, NGOs, have made a lot of money by pumping up prices. It's an industry. So governments were rightly sort of suspicious of that, but it doesn't take away from the fact that these were governments which did not effectively respond to the crisis. By the time they responded to the crisis or began to realize that there was a crisis going on, it was too late. It had gone out of control. But the signaling that this is a crisis of international dimension, credit must be given to the economic community of West African states. Because very early on in the game, they are the ones that said that this is not simply a case of localized outbreak. We have a crisis here that's a major crisis, and it's going to be a security crisis, not only to the region. Sorry, I couldn't answer all of your questions fully. Those are my quick responses.
Yeah, thank you so much, Dr. Rashid. My name is Yusuf Dila. I'm a physician, and I will say I was privileged to witness and experience the role of Ebola and while in Sierra Leone. So I just wanted to highlight some of the things that you mentioned about the factors that were really important in spreading the Ebola. One, I would say fear was very important because initially Ebola started, people did not know much about Ebola, and Ebola was like indiscriminately killing both the patients and the healthcare providers. So it was really it was like a big factor that was really influencing or playing around the issue of denial in the community. And then the information flow was also not helping initially when people were saying that Ebola is deadly, there is no cure for Ebola, you should report your patients to the hospital, you should not touch them. And this was not like clicking with what the perception of the population was. People were really very much attached to their patients, so they wouldn't like to dump their patients to the hospital and not touch them, not have any information about them. So that was also not helpful. And then the lack of knowledge, as you said, was also key because initially the treatment protocol was just only oral administration, like ORS. It was only later that we realized that we have to give IV fluid. So then so many patients died before we kind of changed our treatment protocol to IV fluid in addition to ORS. And also, lastly, you mentioned about the response was really very slow from the international community, WHO, and even the government. It was really very much, downly played initially, but then later on, everybody knew that it was like a very big public health emergency. That was the time support started coming, and the ending the act.
Thank you very much, not only for your intervention and comments, but also for the work that you did in Sierra Leone. I mean, as I said, Ebola has so many unsung heroes.
Well, he's definitely one of them. That's part of the well-bodied PIH team in Koidu, and really helped to jumpstart the reopening of Koidu Government Hospital. Because as most of you know, and as the people up here giving the talk know, one of the first things that happens in an Ebola outbreak is the facilities get shut down, and all schools. So no schools of any kind, and basically the public institutions and private institutions were closed. So DIVA back there was key to getting a lot of services open fairly early and to keeping them open to this day. So, great man. Is there time for one little? Yeah. So I want to add on to Yusuf's point. Thank you.
Thank you for the after
They had a class now. Having that, not the temporality of the historians, but the temporality of just watching things happen over months. I'm going to just try something out that I saw, which is a little bit different from what Yusuf said. Same time, same place. These campaigns that I think deserve our mockery, not the people who did the campaigns. Like, Ebola is real. To have that be the primary message when nobody doubts its realness, it's killing their families, it's shutting down schools, roads, everything. And it's obviously related to the idea that the very common notion that Ebola is caused by something else, also invisible, because not a virus is invisible, also poorly understood, also not well known. So that was the origin of Ebola is real. So if you say, well, yeah, maybe it's viral disease, but clearly there's witchcraft involved because what? So that everybody knows that it happens all over the world. It happens in Berkeley, California, probably at Vassar too. People have weird ideas about what caused illness. So acknowledging that, right? What caused Ebola to what caused it to turn around? And when I ask that, I say the Atlantic Ocean. I mean, nothing stopped it. It went all the way from the point of origin, so it couldn't go anymore. And then it took a couple planes and boats, no doubt, right? But health education campaigns cannot be shown to have stopped it, right? So, and somebody's do some rigorous empirical analysis about this that has to be processual. Here's the thing I want to try on. Having gone through June of 2014, when it was clearly in all three countries, but not recognized yet in Sierra Leone, to now, and especially through that entire year, it seemed to me that the health campaigns, IEC campaigns, weren't very effective. They were also incorrect, right? Like eating bushmeat is not what's causing this epidemic to move forward. But some of the legalistic interventions, heavy-handed interventions, had the impact of relieving family caregivers and so-called traditional caregivers from exposing them to enormous danger at a time when they knew they were facing enormous danger. Now again, this is impressionistic. I didn't do research, but that happened, in around October and November at the height of the Western surge, in Port Loco and across the Western District. So, I mean, maybe Koidu was different, having already been washed over. But at the height of it, when there were hundreds of new cases a day, and Port Loco and Freetown were the epicenters, it seemed to me that people were relieved to be told, you can't do this. You have to have help burying the bodies. You have to. Now, that didn't mean there weren't attacks on burial teams, right? That there were more in Guinea, probably.
Yeah, that's all.
And it's just like, I'm wondering what you think of that.
No, I agree. I mean, because as you said, I mean, the sense of bewilderment, some of the senses of resistance might be early on in terms of the lack of trust, the lack of validation. But one of the way I just said, I agree with you that October becomes in the various plans of bending the curve. October becomes a very critical. October to December becomes very critical when you're looking at 215 to 215 October to December. It becomes very critical because a number of things is kicking. A number of things are kicking. So let's backtrack a little. The survey, the isolate, the contain. These are not, by the way, all of you guys who are sort of doing medicine understand that with infectious disease, these are key. And in a way, they're not alien. They're built into local cultures in terms of people having contagious disease, is that people realize that if that one person goes and sees this person and 2 or 3 days later that person gets sick, maybe what we should do is we should isolate this person. And in different communities, the healer's place is usually out from populated areas. So the survey, isolate, contain is something that's already sort of built into that. The reason why I'm saying that because by October, the message, the resources, and the leadership kick in. And the awareness or the knowledge of the lethality of the disease simply beyond Ebola is real becomes apparent in people's minds. The country by that particular point in time was on a lockdown. So this is a country where we might not have a certain, I think, coverage, internet or phone coverage, maybe 30–40%, but messages go around. So that locking down, that sense that there's a crisis here, sometimes prompts people to begin to respond to particular forms of leadership. And for that brief moment, the Sierra Leone government, once it realized, the Guinean government, once it realized that we're dealing with something that it's not only dangerous to the society, it's also potentially dangerous to us. This is something that is probably going to lead our governments to collapse, also kick in and get on message. So, as you said, the governments were on message, the international community and supporters were on message, the resources was beginning to come in. People began to get the message about the fact that bodies are potentially contagious and that they can kill you. Guinea, there was a resistance before you got to the negotiation. And again, sometimes we kick back against the Red Cross. I think the Red Cross and other organizations, Good Samaritans in Liberia, did a good thing, which was saying that given some of the cultural norms around barriers, we can negotiate a way in which we can have safe barriers. We can have safe barriers. It doesn't take away from some of the tragedy. I have a very good friend that I used to say that died, probably not of Ebola, that was buried in one of the mass graves that you saw in the picture. And it really hit me that particular day on it. He might have died of Ebola, he might not have died. But you have to put in people's psyche of seeing people's body being dumped on mass graves. But you're correct. This is the point, and I agree with you, that sometimes this is not, Sierra Leone is not a traditional state. It's not a traditional state. In a way, it is a modern state living in a modern world. Some of the paraphernalia of state that it has, even if they're not working, speaks of modern world. And the majority of people, Ibrahim Abel and I had a very fascinating conversation when we launched this book from Liberia and was coming to Freetown. Now, sometimes people who are cultural and nationalists say, oh, this is people's traditional culture. We have to celebrate, we have to preserve it. Nobody wants to live in a mud hut, except if you're a tourist. Nobody wants to go to school under a tree, except, you see, there's something fascinating. People want to live in the world as it is, and for the world to respond to them in terms of what the world can offer to make their lives better. Sierra Leoneans want good access, and most Africans and most people around the world want access to as good as medical treatment as they want. They want access to good education. They want access to good houses and good places to live in. So even in local politics, when we have the discourse about these are my people, I need to protect them, I would say, no, it can't be your people if they're your people. They wouldn't be living in slums in the area. So this is what we're having is you're playing funny political games, and we know how funny political games look like. Yeah.
If I could try out one more thing that was going on, it would be, if there's something that physicians, social scientists could add, I think it would be, and Dibba was doing this, a critical discussion of treatment, right? Because there's this enormous and often willed confusion and mystification about how this disease presents, what are the chief signs and symptoms, and how it's managed. So that fight about proper management, which was really, is oral rehydration adequate? Well, what if you're vomiting? What if you lost 10 liters of fluid that day? Even the most ardent chugger of Pedialyte can't replace 10 liters of fluid. And so this was going on in the medical community, which in this case includes the public health community, and they were like, oh, we don't give a shit what they get. Just contain the disease, right? Which squared with a lot of political interests, right? Containment is the only priority. But that's not the priority of clinical medicine. Clinical medicine's priority is to take care of the person or persons in front of you. So this class was going on all throughout the summer and had gone on in previous outbreaks that endured in any way, right? And in October, when those sets, the list that you came together, when that all happened, something else was happening in October as well. That's the first time there was an integration of prevention and care, of containment and caregiving, right? Because before Hastings opened, you had Kenema, which the public health people were trying to shut down, right, and replace with a purpose-built ETU, and Kailaun, That's it. You had two places on the other side of the country. So the heavily populated side, they were still transferring patients across the country overland, right? So, I mean, who wouldn't flee, right? Who wouldn't run?
Yeah, and
everybody did.
And it's a long, for somebody who probably showed this, it's a long, arduous journey.
But in October, you got Maforki across the country. There started to be, and Hastings being one of the best of them, you know. So, I you know, in putting this together, as you have done already, but you know, if that a list of things that began to happen when that periodization, you know, was October was a key month.
And it's integrating, because this is, again, it's thinking of it, as a historian, the two things I'm sort of always sort of interested in. One, conjectural crisis, is that riots don't happen. Revolutions just don't happen. There are no monocausal trends to events. It usually takes a combination of things. For real change to happen, or for society sometimes to break up, sort of fall apart. But as you say, the key here in thinking about what's going on, and also in terms of also public response to what was going on. October, December, as you said, people could come to the centers. There will be the containment units for patients, but people could see their loved ones. People could communicate through signs. So that sense that sense in which it's not simply about treating the body, it's also treating the body within sort of a social context in which people are fighting or sort of responding to disease with the knowledge that the world, it's not only their body that is completely disintegrated. It's not, even if their body is disintegrating, the world around them is not disintegrated. And I think that sort of made, as you said, sort of a difference. Doing that and connecting that with the fact that you can't lose sight of some of the cultural context that's attached to burial. It's not that we shouldn't glamorize or we shouldn't think about cultural burial, because cultural burial is also undergoing change. I was born and raised in a Muslim community, which historically did not used to put people in funeral homes. Now we do. So these are the sort of not fixed cultural sort of practices. They change over time, but that change has to be told about and has to be two things that I want to end up with and just go quick. And this is because what first, Ebola was a Chiara's disease. Most of the people who died in Ebola, most of the fatality for people who are not infected or people subsequently was Chiara's. Doctors, it's not surprising. Nurses, it's not surprising. Family members, it's not surprising were among those who got the disease very early and died from the disease. The second point that I needed to underline that's part of this larger story, it really speaks to the issue of political, economic, and structural violence. And I hope that more work is done on this, because, as you said, I mean, based on impression and knowledge of the country, that the places where people died most and the places where people were most affected were among some of the poorest communities in Sierra Leone. So let's say you come from my family, which is lower middle class in Sierra Leone. I didn't lose a single family member, but there were people who were living in informal communities and who were really rural migrants who really in the city took a hit. It's not surprising that Port-Loko and those other areas took a hit. Northern region in Sierra Leone, in terms of economic development, is one of the lesser developed of the countries. It's not surprising that Kenema and Kalam were epicenters. Those were areas that were seriously hit by the civil war. Kalam is among the most, it's one of the least developed districts in Sierra Leone.
I think we have another question.
Yeah.
Well, it wasn't a question, it was more of a comment.
Okay, go ahead and introduce yourself.
Victor Yukatu from PIH. I can't really speak for Sierra Leone and Guinea, but I could speak for Liberia in a sense. Just to touch on the campaign of Ebola is real. From my perspective, at least the community here, we thought that was very effective in a sense. I think in a country like Liberia, it's a cultural thing, and not only is it a cultural thing, but the phrase Ebola is real means different things in different contexts, and that's a lot of things in Liberia, like I'm inside, or we're inside means different things in the context that you use it. And a country like Liberia with the culture where it's very hopeless and very kind of, we take whatever comes at us, people don't necessarily take those things important until the ball drops. So at the campaign, we all kind of pushed Ebola is real campaign, because it didn't just mean, well, this virus is real. It also meant this is serious. This is killing people.
And I shouldn't have been so dismissive. If I can, may I answer this? The Ebola is real campaign, not in the context that you said, where it was a conversation about the gravity of Ebola. It was usually followed by long stentorian lectures about how ignorant peasants believed in superstition, witchcraft, sorcery, etc. Those were tightly linked in the mainstream public health IEC, IEC response that I heard. But it's a point well taken, Victor, that the slogan itself is not the problem, right? Because it's the same, as you know very well, same here in the United States. People say, reals. It has lots of important signification. It was really the mishmash that followed that was a problem. And like I said, you go to Berkeley, California, you wouldn't believe some of the things people believe. I mean, our anti-vaxxer movement is larger than many in Africa, right? And it's so very good point.
And again, I honor that particular point because West African context, I know what the statement was trying to get is that yes, the state lies to you, and you'll be suspicious of politics and what goes on, but you have to stop and take this. Yeah, so I get that in terms of really the suspiciousness, the alienation that is going on, and the way in which that might be connected or not connected to the disease. So on one particular level, it speaks to the disease. At another level, it actually speaks to the relationship between the states and medical practitioners.
And just to get this out of the specifics of the slogan or the term, one of the questions asked in the book and asked by his whole body of work is really about history and political economy. And to go back to old 19th century terms, is a cognitivist intervention, right? That is a set of lessons for an audience, right? Stop doing this, start doing this, Ebola is real, Ebola is not real, go to a hospital, don't go to a hospital, don't eat bushmeat. Those are orders being given to a crowd, right? Or a cognitivist intervention. I think one of the points the book makes is this is not primarily a cognitive matter. It's not people's ignorance, it's their lack of access to the a medical system that can both protect them from epidemic disease and take care of them when they're sick. So it's that materialist, it's the materialist as opposed to a culturalist, right, or a cognitivist. That's kind of, like when you say you open up Ebola treatment units in October, that's a material intervention with bags of IV fluids and people to take care of you. So that's another part of the whole IEC debate.
You wanted to make I thought you.
Me?
He just gets eager like that.
I hadn't raised my hand, but sure, I'll ask a question. It was really wonderful to read your article on epidemics during the First World War, and then see, as you kind of pointed out, the echoes with respect to the Ebola epidemic. And I was wondering, the similarities are very striking, and yet they tend to be very unknown. I think one could argue that public health in general tends to be devoid of history, of political economy, of social sciences, and
I was just wondering, what do you think is the best way to engage public health professionals, academics, in the history and the political economy? Because I think it continues to be one of the biggest problems, and even students among us have noticed that there is a big divide, in the types of approaches and the methodologies and disciplines that are used to teach, where it's such a quantitative discipline that doesn't consider historical context, and yet those insights are so important. How do you think we can do that better? In other words, you are very rare, I think, in public health, someone like you, and the type of things that you teach, and how might we better address that?
So first, this is what is it? The room speaks for itself in terms of the invitation to come here, to converse with you, which, as you said, it's a completely sort of different approach. I remember way back then in the 90s, my own ambassador was doing this kind of work. He was the one who was moving across the building, not the other way around. So I welcome this conversation, and I hope that you guys will continue to do what you're sort of doing here and through PIH. But also, I think, also equally important, and this is with UGHA in Rwanda. I think it's building that into medical education. It's building that into medical education so that we ultimately end up in what we're talking about, so the October moment in Sierra Leone, in which really, and to a certain extent, we're talking about old alignments and old understanding of not only the body and sort of the body goes through life, but also the body in society.
Well, I didn't pay him to say that. UGH Antito,
Yes, I have a quick question. So I am Antito and I work for Vassar, and I'm also from Haiti, and we have a lot of social issues and political issues in Haiti, and the big problem I think for government is to prioritize what they should be working on. And I know sometimes government and the people, they have different priorities. So in terms of Sierra Leone, what are the priorities for the government and for the people, and what is the difference in priorities for both groups?
Hey, look, the government won and we voted. They got by 50,000 votes, I think. They're in government simply because they said free education. They said free education. So because of the cost of education in Sierra Leone and because of the expansion, the need for educational facilities and opportunities for young people, is that people voted for the government. And the other priority would be employment. Health would come sort of a distant third in that particular sort of hierarchy of things. So the government is now busy trying to make, they've already started the year with the free education, trying to put the campaign in action. There is, by the way, it's not a policy that is thought out very well. I asked, I said, so you're doing free education, why is the policy that speaks to this in a very long term and very sustained way? There is no policy behind that. You're right. I mean, again, one place to turn, I think that really so far in terms of what the record is showing that I think has prioritized this fairly well is what Rwanda is trying to do. It makes it very clear at any given point in time. I'm always very suspicious, especially developing countries when Africa says, when African government says, we have 10 priorities that we have to meet. No, you can't meet 10 priorities. I like Rwanda, where I think the Kagame government has said health, education was the third priority. Alien and sort of responding to the genocide. So it's a manageable set of priorities. Education is important because we want our citizens to live in the 21st century. We also want them to be skilled, to have the ability to be able to respond to and deal what's going on. If your population is not healthy, people are not at most part of their life at their optimum, you're going to get very little from them, and they can't change or transform society.